Mayank, can we go live now?
So we are good to go.
Thanks. So with your permission, can we start?
Yes, sir.
Yeah. Good evening, one and all. I am Prashant Agrawal, General Manager with Emcure. Today we are going to have 9th session of No Thrombosis platform under leadership of Dr. Subhash Kaul. We are going to have very interesting clinical dilemma, differential diagnosis cases of AIS. We are going to have today eminent panel with us, and I take this opportunity to introduce this all to you. We have our course director, Dr. Subhash Kaul. Dr. Subhash Kaul is MD DM from the PGI Chandigarh, and currently he is senior consultant and stroke specialist based out of KIMS, Hyderabad. Sir is associated with NIMS Institute for 27 years, and he is former professor and head Department of Neurology and Dean at NIMS. Sir has over 120 publications in national and international journals, and he is principal co-investigator of several national and international projects, including largest single center Hyderabad Stroke Registry, which is funded by ICMR. Sir is also state teacher awarded by Telangana government 2017. He is past president of AP Neuroscientist Association, past president Indian Stroke Association, and past president of Indian Academy of Neurology. Welcome on board, sir. We have our moderator for the day, Dr. S. Meenakshi Sundaram. Sir is senior consultant neurologist, Apollo Hospital, Madurai, and has over 20 years of experience in neurology. Sir has presented many papers in various prestigious national and international forums, recipients of Best Research Paper Award at the 10th Annual Conference of Indian Academy of Neurology, Lucknow 2002. He is principal investigator for many international trials such as refractory partial epilepsy, stroke, acute stroke interventional trial, and PD trials. Sir is editor of South Asian edition of book Practical Neurology by Joe Spiller by Walter Clover in December 2020, and he has also contributed to many books on neurology. Welcome you on board, sir. We have our guest moderator for the day, Dr. Saroja, Dr. A.O. Saroja. Ma'am is professor and head Department of Neurology, Jawaharlal Nehru Medical College, Belagavi, Karnataka. Madam has over 27 years of teaching experience in neurology, and she has areas of interest as cognitive neurology, cerebrovascular disorders, epilepsy, and neuroinfections. Ma'am is being awarded with Best Poster in INCON 2022 and Best Clinical Paper 22nd World Congress of Neurology in 2015 at Santiago. Welcome you on board, ma'am. We will be having our first presenter, case presenter, Dr. Abhishek Wankar. Dr. Abhishek Wankar is consultant neurologist at Alaxis Multi-Speciality Hospital, Nagpur, and has various publication, poster presentation at conferences, and he has special interest in stroke and electrophysiology. Welcome you on board, sir. And we have today our second case presenter as Dr. Sastara P. He is an assistant professor at JSS Medical College, Mysore, and has various rewarding scientific careers in his journey so far. Welcome you on board, Dr. Shastara. So without building much, I hand over to Dr. Subhash Kaul for taking it forward. Over to you, sir.
Yeah, thank you, Prashant. So those of you who have already attended this program or have been attending, you already know about this program. And those of you who are new, this is a program in which interesting stroke cases are discussed. So it's a very interesting and informative forum because, as you know, each stroke patient is different. As Miller Fisher said, neurologists learn neurology stroke by stroke, and that indeed happens. And a lot of times there are no clear-cut answers, no clear-cut guidelines for dealing with individual cases. So usually in our day-to-day study of textbooks, these cases do not come alive. But in forums like this, and there are very few forums like this, where cases are discussed. Otherwise, what is discussed is data. And data is an average of thousands of patients. So these individual scenarios, individual challenges get lost in that. Therefore, I think Emcure has done a great job in organizing this forum, which has been going on for many months now. In fact, I'm in Goa today. There is a CONI meeting going on here, a neurosphere, and it's only debates. And today there was a debate that Tenectase versus Elteplase. That is the usual debate. And in that, the Tenectase won hands down. So I thought Emcure team will be happy. So with that, I think I'm very sure today I welcome Saroja also. Saroja is a dear friend, and she is a very eminent neurologist. I know her. She and Ravi, her husband, they are all very eminent neurologists from Nimhans originally. So we welcome her also as a moderator, and of course my friend Meenakshi. So I hand over to them, to Meenakshi Sundaram and Saroja to take the program forward. Meenakshi, please.
Madam.
Thank you, sir. Thank you very much. And for that kind introduction, we always cherish your friendship, of course. And we learned a lot of things. And whenever I remember Subhash thought, it is mechanism of stroke. He keeps telling on mechanism of stroke, which is the basis of treatment. And I think we welcome both the speakers. And probably, I think, Meenakshi, we can welcome the first speaker to present his case presentation.
Of course, madam. Please let him go ahead, please.
Thank you. Thank you.
Dr. Abhishek, you will share the screen. Or should I share, sir, from here? Yes, sir, your screen is visible.
Dr. Abhishek, your screen is visible.
Dr. Abhishek, you can put this on slide mode so it's fully visible. डॉक्टर अभिषेक आपको आवाज आ रहा है? Sir, your voice is not coming to us. No, sir, your voice is not coming.
So please select the small arrow beside the mute or unmute button, and you can put it on same as system mode. So your voice will be visible. Your voice will be audible.
Means he has to stop sharing and resharing, correct?
Dr. Abhishek, is there a problem?
Yeah, I think, he is not able to, his voice
Sir,
is
please,
not reaching us.
Dr. Abhishek, please press the button, arrow button beside the mute button, mute unmute button. There you will find an option of same as system, and you can select that.
मैं फोन करता हूँ सर को. Dr. Abhishek, can we start with Dr. Shastrava's case? And meanwhile, I'll connect with you, sir.
You can send a message to him.
Yeah, ma'am, I'm speaking with him.
Okay.
Yeah. So may I request Shastra sir?
Yes, sir. Sure. Should I start?
Yes, sir.
Yes, sir.
Dr. Abhishek, you can stop sharing your screen.
So can I go ahead?
Yes, Dr. Shastara, you can start now.
Yeah. Hope I am visible and audible.
Yes.
Yeah. It is my proud privilege and it is a great opportunity in front of all stalwarts, and extremely humbled for this opportunity because Dr. Saroja, I know her personally. She is our teacher, and all other eminent moderators, and Dr. Subhash sir. We all have heard you in various conferences and learnt a lot in our student life. And I'm extremely privileged to get this opportunity as a young budding neurologist. It is a huge opportunity for me. And although we discuss a lot of complicated cases here, we discuss a lot of things which are having diagnostic enigmas, complications. Let me try to go back to the basics, because many times we tend to forget our basics. And as a basic neurologist, what you can do as a at the bedside level or at the basic level of our country, where we are still resource poor, and what we can do and how we can make a difference in patient's life. That is what I'm trying to emphasize with this particular case. So the title which I gave here is Simple Case of Thrombolysis with Ample of Happiness. So here it is nothing extraordinarily complicated. It is extremely simple case. But what I would like to highlight here is 2 or 3 things. So one is the age of the patients. Second thing is short-term follow-up. Third thing is long-term follow-up. Because many times what happens is a clinician's job is like, whenever the temperature touches normal or stitches are removed, a doctor's job is over. Probably that is not the case with neurologists, because all our disorders are chronic and long-term, and the rehabilitation part of it, and we have to see the patient on a follow-up basis, which will make a huge lot of difference in patient's life. With that small introduction, let me go ahead, and I'm extremely grateful for this particular opportunity. Thanking again to the entire team. Going further. Yeah. So we had a patient who was a driver of an entrepreneur, was traveling from Bengaluru to Mysore when he developed weakness of right upper limb at the outskirts of Mysore city. It is actually a scenario that has happened in real, and there is nothing hypothetical in this. He is a driver of an entrepreneur, and they were traveling from Bangalore to Mysore. Midway, almost reaching the Mysore's outskirts, he noticed to develop a weakness of right upper limb. He stopped his car in the middle of the road and tried to get out of the car. Unfortunately, he was not able to move his lower limb as well properly. There was also a component of receptive aphasia. This happened all of a sudden. He had impaired glucose tolerance and dyslipidemia. Otherwise, he was not a smoker or a ethanolic. Owner himself, luckily, he was kind enough to drive the car and take his driver to the ER. He rushed to the ER. So this is a story of a young male who was driving car and developed sudden onset of right-sided weakness with receptive aphasia and had rushed to the ER. Before this story rolls out further, there are some facts which I'd like to highlight. As neurologists compared to the cardiologists, even now, our rate of patients thrombolysis is very less. The reason probably for that is we don't consider stroke as brain attack. We all think heart attack is very severe and brain attack is not that severe. This is a perception that is happening in our general public. So if you take an Indian perspective, we know that one stroke happens every 40 seconds, and there is a significant cause of morbidity with a stroke. And we can see here, ischemic stroke is lion's share. It is more than 87% in US and around 80% in India. And hemorrhagic stroke is less common. So why I put this particular slide is because before unfolding the case scenario is the gravity of the problem we should be aware as neurologists, as well as the people who are listening to this and general public and community should be aware that because brain silently cries, it doesn't give pain. The lack of pain is probably the important reason why patients don't rush into hospital, and we have a lot of dialysis that is lost, the household income that is lost, and the occupation that is being lost. So going further, we all know the stroke is the one which is causing, it occurs almost 15 years earlier in the low and middle income countries compared to the developed countries. So we have stroke in much younger age group, which I'm going to highlight in my case as well. And the burden of this is much more severe because he has to withstand that morbidity for lifetime. That is the reason why 1.8 million people in India suffer from stroke every year. So time is brain, we know very well. I'll come to that with my case as well. So every stroke will make us lose 1.2 billion neurons and 8.3 trillion synapses and more than 7 kilometers of myelinated fibers. And we age by more than 36 synapses, more than 200 meters of myelinated fibers, and we age by more than 8.7 years. So time is brain concept is still relevant, although we have certain concepts which is talking against this with all our development of perfusion imaging and mechanical thrombectomy, which is not probably out of scope on today's topic. So we all should be aware before I go into the case that NNT is very important, because for the benefit of students who are listening to this, number needed to treat is extremely important. In thrombolysis case, in this particular case scenario, we put thrombolysis patient within 1.5 hours. As we increase in our time duration, NNT goes on increasing. If we thrombolyze at the uppermost window per period of time, that is 4.5 hours, it is around 14. Whereas from the 19 minutes to 33 hours, it is around 9. And less than 90 minutes, it is 4 to 5. So NNT is far less if you thrombolyze earlier, and higher the duration of the onset of dim symptom and the thrombolysis, that is low to needed time, the NNT goes on increasing, which makes a lot of difference in patient's outcome. So in this particular patient was conscious, obeying commands, but there was some amount of receptive aphasia as well. There was combination of receptive as well as expressive aphasia. I'll tell you the reason for that. And he had right hemiparesis of 4.5 and NH score of 8 out of 42. My highlight in this particular case is the videos, because I have closely followed up this particular patient on 3 consecutive occasions at admission, during the follow-up of 3 months, 6 months, and 1 year. We can see very clearly that on the first admission day, he was having a lot of difficulty in walking. He is having classical circumflexion gait, and he has difficulty in walking difficulty in gripping, as well as the fine coordinate movements in the hand were impaired as well. What was there in the imaging? Imaging was showing diffusion restriction with diffusion flare mismatch. These mismatches are very important to match a patient for thrombolysis. So more the mismatches, better for us. If there is a lot of collaterals, less infarct, better for us. Lot of penumbra, less score is better for us. And if you have advanced images like perfusion imaging and diffusion imaging, again, mismatch is better for us. Core volume mismatch is important for us. So if you have NHS mismatch with aspects is important for us. So a lot of mismatches will make our life easier, or that make the patient to match for a better prognosis. So in this particular patient, we didn't do a lot of advanced imaging. Again, I'm going to have emphasis because I am not talking in a complicated case. I'm basically highlighting on a simple case as a general neurologist, as a neurologist in a moderate, like a tier 2 or tier 3 city, how we can make a difference. Suppose we don't have a lot of advanced imaging, we don't have perfusion imaging, diffusion imaging, and so many other fancy things. Still, with the basic setup of CT or an MRI, how we can make a difference. In this particular case, we looked into a basic concept of diffusion flare mismatch. We all know very well that with increasing time duration, lot of emphasis is being given for this mismatches, because lot of trials like wake up trials where we try to thrombolyze patients when the onset of the disease is unknown. And many of the trials like recent Chinese trial where they have tried to extend the window period of thrombolysis, all of them have relied on this particular mismatch. In this patient, we can clearly see in the temporo-occipital area, in the junction, we can clearly see there is infarction, that is diffusion restriction, and the flare imaging, it is not very clearly seen. So this explains his right side weakness and the aphasia as well. As we know very well, the aphasia concept is a little bit blurred nowadays. We may not have classical Broca's, Wernicke's, and global, what we were talking earlier. It is more of networks and node hypothesis now. That is why this patient had got combination of both the types, and which like our classical MBBS teaching, things have slightly changed with the onset of with the functional MRIs that we could appreciate in this particular patient as well. So what is the message in this particular MRIs?
I think, sir, no, there is some network issue at his end. So he is joining again, sir, it seems. He has joined back.
So thrombolysis has a lot of hurdles. You can see that, right?
Dr. Shastara, you are mute.
Am I audible?
Yeah, now, sir. Very well, sir.
Hello.
Yes, sir,
Yeah,
you are
yeah.
audible, sir.
Yeah, as clinically we have a lot of hurdles for thrombolysis. Even in our topic today, we have a lot of technical hurdles. We have to wade through all these things because in the practice as well, thrombolysis has got a lot of hurdles, and that is signified or justified in this particular topic as well. Anyway, with that sense of humor, we'll go forward because we have a lot of technical glitches today. Yeah. So that is an MR angio showing, there was cutoff beyond M2, M3 segment, so it was not clearly visible. I think diffusion flare mismatch I had already explained. So we all know we have timeline for management of stroke, just to put in 2 or 3 slides. So we have to go with the time. So 0 minutes, 5 minutes, 10 minutes, and coming to the 15 minutes, 25 minutes, and 45 minutes, every minute is crucial for us. In this patient, we accordingly followed the algorithm and we immediately determined his, basic parameters was done instead of CT imaging, MRI was done here. We activated the stroke alert, imaging was completed within 30 minutes, and imaging was interpreted as well, and we immediately started the therapy within 60 minutes. So this was the so-called concept of golden hour, which was referring to MI, now to the stroke, and all of them are alike basically because everywhere the vascularity is at jeopardy. So we can see here within 60 minutes, the idea is to give the thrombolytic agent. This Dahl's poster is very, very important because what happens is the changes in the final outcome that happens over a period of 3 months. Functional independence, that is MRI score, is 62.52%, and there is no major change around 35% of patients, and hemorrhage happens around 1.8% of patients. So this has to be very clearly understood by all of us. I know all our esteemed moderators and our faculty know this very well, but for the benefit of students, we should know that we shouldn't have that phobia or the fear of administering thrombolytic agent, because neurologists by default have an inertia to administer thrombolytic agents. Many of our esteemed neurologists are octogenarians now, they have that inertia, thinking that it may not be good because a lot of bleeding. But what we should finally remember is the risk-benefit ratio. To take the risk-benefit ratio, this slide clearly tells that intracranial hemorrhage is hardly 2%, less than 2%, and more than 62% have a good MRI score and good functional outcome. That is what I'm going to highlight in this particular case. So we have gone through this criteria of eligibility for thrombolysis, and this patient was more than 18 years of age, had onset of symptoms less than 4.5 hours, and he had got clinical neurological deficit, and he had no evidence of any other exclusion criteria that is getting satisfied. He doesn't have any past history of bleeds or strokes or malignancies or neoplasms or GI bleeds or coagulopathy or thrombocytopenia. So that there were no other warning signs, and he was hemodynamically stable. So we had a license to go ahead with the thrombolysis. So window period thrombolysis, we have got a lot of concepts here. Here I am going to highlight only on one molecule, and with one molecule, just one molecule, how made a difference in the patient's life. So it's always, we should remember probably as a budding neurologist, is lot of fancy stuff, lot of imaging, lot of money may not be there for everybody. So as a person who works in a district hospital or a small city, in those areas as well, we can make a difference with just one molecule without much fancy imaging, with a good clinical acumen. That is what I'm going to highlight in this particular case. Here we didn't do anything extraordinary here. A basic MRI was done, basic blood was done for basic blood test, and with the guidelines excluding exclusion criteria, he was given 0.2 mg per kg of tenectase within 1.5 hours of onset of weakness. We all have the debate of tenectase for 3 hours, 4.5 hours, alteplase versus tenectase, and so many things are going on. But in this particular patient, anyway, whatever it may be, the Indian guidelines or Western guidelines, he was satisfying into the guidelines criteria of tenectase, and he was thrombolyzed within 1.5 hours, and he was very closely monitored, and his ICU stay was uneventful. CT we can see here. All the concept about stroke is, if you have a lot of findings in MRI or CT, if you see a CT something like this, probably we will not dare to do thrombolysis if it is a first CT, because we know that CT will take time for the infarct to establish, and these patients may not do really well with thrombolysis because the collaterals are poor. This particular patient, what was surprising was, despite CT was showing very florid infarct, which is very much visible in the junction of temporal and parietal area, and it is very evident that despite patient having a reasonably good deficits, which was hampering his routine activity. Because of the young age, probably because of the good brain reserve and because of the good response to the therapy, he did very well in the follow-up time. So what happens is that inertia in us to thrombolyze, looking into the CT or MRI, especially in young patients, probably has to be avoided, because these patients, if they satisfy the criteria of thrombolysis, we should still go ahead because they can do very well, as I show in the further following videos. Please see this video. We can see after 3 months, he hardly has minimal deficits. He's walking in much better fashion compared to earlier. I can play it again for you. So you can see there is minimal deficits now, but he is able to do independently his activity, although he was not functionally fit to become a driver again. But 6 months later, the things have changed. You can see very well his walking speed has improved, his gait has improved, and he is walking quite comfortably. And there is hardly, for a naked eye, there is not much of difference. And we can very clearly see from the first video compared to the third video, there is a paradigm shift. There is a very significant improvement, which actually makes us to feel very, very happy. This is probably one of the accomplishments a neurologist can get. One could be correction of hypoglycemia patient waking up his eye. One is a stroke in young patient who is not able to walk at all or unable to do his activity, becoming normal. These are one. Third would be probably hypokalemic periodic paralysis when patient gets up. These are the certain magical things we have in life, although many of the neurological disorders are not magical. This is an important video I would like to highlight. After 1 year, probably I may not be able to tell this patient had stroke at all in the past. So you can see his gait is very well maintained. He is able to walk freely, confidently. His arm swing is almost normal on both sides, and there is the component of circumduction gait has disappeared, and the heel walking we can see that is with the footwear on is able to do it very well, and even the toe walking part of it was also is able to do well, and he is quite happy. And you can see he is going to outstretch his hands. He is able to flex his fingers, and he is able to pronate, supinate, and most importantly, the fine coordinated movements, which are very, very important, because I've got a largest representation in the brain, which is an important thing that is to get hampered in stroke patients. He has also come back. So we can see the video again. He is able to walk freely, come back freely. Heel walking is normal, toe walking is normal, and most importantly, the fine coordinated movements. So our old story of our Ekalavya, where the thumb, our Indians have showed that thumb is extremely important for us, because without that, the Bilvidya is not possible. That is very important in our stroke as well, because the thumb is the one which is very last to come, especially if it is that area. If that area is infarcted, that is the thumb which comes very, very late. But in this patient, likely for us and for our good luck, the thumb has come back, the fine movements have come back, and is able to carry out fine coordinated movements as well in a very good fashion, which is an accomplishment for both of us. So patient is happy, the doctor is happy, and this is what probably is accomplished for a neurologist or a clinician. So the entire stroke workup for young is done because he's a stroke in young. He had only impaired glucose tolerance and dyslipidemia with no other identifiable cause. This is true many times. So-called cryptogenic strokes, what we used to call earlier, which is nothing but due to either due to an paroxysmal AF or which is a hidden thrombus going into an embolism, or many of the hypercoagulable status. So all these things have been ruled out. We have done a Holter monitoring for him for 7 days. Even loop recorder has been done. Everything has been done. Cardiac workup has been done. Thrombophilia profile has been done. Everything was negative. Many times in practice, we have seen that although we give big list of causes for stroke in young, many times we don't find anything. This is extremely true in our scenario, because many of our patients are not affordable for many of these things. So at the end result, they may ask, after doing all these things, what is the end result? You are going to give the same drug for us. So that is why this is important, because in this case, he was the owner was kind enough to get all these things done, but the outcome was nil. There was no identifiable cause other than mild dyslipidemia and impaired glucose tolerance. Antiplatelets is very important, because many times we make mistakes here. We give thrombolytic agents, and what next is an important question, because this may be a simple issue for many of us, but for a student who is listening to this project, for their benefit, I would like to highlight this, because whether to choose a single antiplatelet or a dual antiplatelet, 150 mg or 75 mg, how long to give, how long to continue, how long to give for, whether to give for 21 days or 90 days or 1 year, all this dilemma, it creeps in our minds, it percolates in our mind every time we ink our pen to give an antiplatelet, because many times I have seen our students making a mistake on which antiplatelet to use and whether the dual or single. That is what I'm going to highlight with this particular case scenario here. So what is happiness here is, happily he resumed his occupation as the driver, driving his life back to the track, and which was at the risk of going off track thanks to Tenectase. So his life, which was about to go off track, came into the track because of this bundle drug called Tenectase, and he was able to drive his car back, which was giving him the bread, the butter, and the jam of his life, and he could regain his occupation back so that he can work again. And I'm happy to know that even he comes for follow-up with me now, and he comes with his owner driving the owner's car, and it gives a lot of happiness as a clinician, and that is what I would like to share here. So I was talking about the choice of antiplatelets because it is a little bit out of context maybe, but it will complete the holistic approach of management, because all of us have confusion regarding the choosing of antiplatelets. In this case, he has got a significant intracranial large artery atherosclerosis, also called as LAO. So that is more than 70%, that is 70 to 99%. So here we choose dual antiplatelets for 90 days, followed by single antiplatelet therapy. If it is intracranial 50 to 69%, if NHS score is less than 5, then probably we are going to give a dual antiplatelets. If it is more than 5, we choose for single antiplatelets. So this has to be very clear between all of us, because many of us students or clinicians or physicians make mistake in choosing an antiplatelet. So ideally speaking, angiogram is mandatory to quantify the amount of intracranial atherosclerosis so that we make a correct choice here. We didn't have any significant extracranial atherosclerosis here, so that question doesn't arise because of the significant intracranial atherosclerosis, and we have a lot of clinical trials which have clearly showed that the medical management is probably superior to surgical management in case of intracranial large artery atherosclerosis on a long-term basis. That is why we have chosen dual antiplatelets for 90 days, followed by single antiplatelet therapy for this particular patient. This is an important slide which most of our students should remember probably, because that will tell us about the use of antiplatelet agents. So tenectase as a thrombolytic agent, few words I would like to put here with an experience of thrombolysis in patients. So we all know tenectase versus alteplase, and the large artery opening is around 6 to 13 in case of tenectase in this particular trial. And we all know that recovery is much better in case of tenectase compared to alteplase with a significant P value. The reason for that is more fibrin specificity, more thrombolytic potency, and more plasminogen activator inhibitor type 1 resistance, and fibrinogen depletion is less, PRT activity is more, clearance is around 1.9 ml per kg per minute, and half-life is much longer than alteplase. Few trials which would support this particular molecule. We all know that there are a lot of randomized control trials which are compared alteplase versus tenectase. And all of them have shown that the quick mode of administration, that is called basically we just push and go. There is no need to do drip and ship here, because alteplase requires dripping and shipping. Here it is just push and go. There is no need to do a bolus dose and a maintenance dose. And there are a lot of trials which have showed that if you are considering a bridging thrombolysis, if you are doing a mechanical thrombectomy following chemical thrombolysis, then tenectase is much better than alteplase, because it saves a lot of time, and recanalization and opening of collaterals are much better with tenectase compared to alteplase. This is a trial which has showed that before thrombectomy, if tenectase is given, it is much better than alteplase. So Indian perspective also has to be kept in mind. We have 2018 Genova TNK, then Kameshwar Prasad landmark study, then DGHS approval, then came the retro study, then AHAS guidelines came, and the further studies are rolling on on tenectase. So are we ready for clinical practice? Because many of the times, a lot of pressures, lot of rules and approval things, we have still with alteplase. So we all know that it has got a longer half-life, increased specificity, reduced inactivation, and it has got both in vitro and in vivo. It has proven its efficacy beyond its doubt. It is basically give and go, not drip and ship, and lot of trials have showed its utility as well. So last few lines on long-term follow-up of this particular patient. Here, I would like to highlight 3 important dimensions in this particular case. One is a time frame. Second thing is age. Third thing is probably the brain reserve, because in this particular case, we are fortunate to get a patient very early in the course of the illness. Despite having significant neuroimaging findings, he did very well. And the long-term follow-up is very, very good. Many of the studies recently have showed that if you compare 2 arms of patients on long-term follow-up, for example, 6 months, 1 year, or 2 years, patients who have got thrombolysis will do much better, and their cognitive decline is much lesser as compared to patients who are managed conservatively or who have not been thrombolized. That is what these particular studies tell. Long-term follow-up is much better, and their economical burden is much lesser, and their morbidity is much lesser, and they would be still continue to remain breadwinners for the family, which can make a huge difference for a doctor as well as for a patient. Especially in stroke in young, the rehabilitation is much easier, deaths are much lesser, morbidity is much lesser, and because of the probably the good collaterals and brain reserve, they do very well on long-term follow-up as well. So that is a conclusion. So we have a short preparation time, no requirement of infusion pump, lot of money is being saved, less of unfavorable outcomes compared to Alteplase, and this is the reason why probably Tenectase has to be chosen as our first line of agent. And my simple message in this particular case is, it is not a complicated case. It is a case which we see on day-to-day basis. But the importance of highlighting this is a young patient who comes in a window period of stroke. We need to disseminate the message of brain attack much more in the general population. As a neurologist, it is our duty probably to disseminate this particular message, because young patients do extremely well despite having significant neuroparenchymal findings of infarction, and they probably do much better than patients and the same age, patients of elderly age population. That is why probably the collaterals and brain reserve are the key elements where patients can do much better compared to the elderly population. That is the message I would like to give in this particular case. Thank you so much.
Yeah, I think that was a good case, Shastra. And I think one good thing in this patient is that he received the thrombolysis quite early.
Yes,
because although we say guidelines say that you can give up to 3 hours or 4.5 hours, but in spite of that, the earlier the better.
Yes, sir.
So the best results are for those who receive it as early as possible.
Yes, sir.
And people, what is called door to needle time. And in developed countries, people have kept a door to needle time as less as half an hour. And your patient also received within 1.5 hours. And that's also one reason why he did well. And I was telling today only we had a debate here in Goa between the two, Alteplase and Tenectase, and Tenectase was thought to be better. There's another advantage of Tenectase because you give it bolus dose without the need of infusion. That clearly we save 1 hour in that. Exactly. Otherwise, the Alteplase goes on for another 1 hour is lost. But here, that 1 hour also is saved. Yes. So I think it's a great case. So Saroja and Dr. Meenakshi, your comments?
Yeah, Dr. Shastara, I think there was a very large amount of discussion that you made. Thank you very much for that. And we don't have time for questions for this thing because time is short. We will request the other speaker, Dr. Abhishek, to present his case.
Yeah. Good evening, everybody. After a very beautiful case, as presented by the previous speaker, I have a very simple 4 cases, and I'll put it as a small case series, and just would like to share our experience with Tenectase. So, first of all, we start with the first case, which is a 73-year-old female. She developed right hemiparesis 3 hours back associated with dysarthria. She had lot of comorbidities. She was a known diabetic. She was a hypertensive, chronic obstructive airway disease, chronic kidney disease, and she came with an NIHSS of 8. Her blood pressure was very high, 182 by 120. So we had to lower her blood pressure, giving her lobetalol. We did her CT head brain, which did not show any significant abnormality. However, patient had
Hello.
Yeah, I'll present it this one. So
I'm just coming. I'm coming.
So the patient had a normal CT, and accordingly we thrombolized the patient with Tenectase 15 mg as per 0.25 mg per kg. Her blood pressure was controlled. Insulin was started in infusion form to control her blood sugars. All the supportive care were initiated, and but ECG showed her to have atrial fibrillation with fast ventricular rate. So she was started on apixaban 24 hours after the stroke. Follow-up of an MRI brain of 24 hours after the stroke showed her to have left MC-tertiary infarct involving frontoparietal lobe with early hemorrhagic transformation. These are the MRI images or diffusion weighted images 24 hours after the stroke, which showed some some infarcts, more patchy infarcts all over the left MCA. Patient had an uneventful hospital stay and was discharged on day 9, and improvement in NIHS was noted from an NIHS of 8, where patient improved to an NIHS of 6, but further follow-up is needed for this patient. Second is a 77-year-old male. He presented to us with aphasia of 1 hour. He had no risk factors. NIHS at admission was 3, and CT had showed ill-defined hypodensity in left posterior temporooccipital lobe, obscuration of gray white matter, but nothing very significant in that. So he was thrombolized with injection tenectase, 10 milligram. Supportive care was started. Aspirin was started after 24 hours. MRI brain showed multifocal areas of restricted diffusion in left posterior temporooccipital and frontoparietal lobes. Left ICA not visualized from its origin, and a good thing was that during his hospital stay itself, we could actually see his speech improved, and he was though with a completely thrombosed internal carotid artery, we were able to get his speech back, and patient was discharged with mild dysarthria on day 5. So the third case is again a 72-year-old male. He presented with left hemiparesis of 40 minutes, slurred speech. He had multiple risk factors. He was a known diabetic, hypertensive, ischemic heart disease, post coronary angioplasty in 2016. This patient had come with a vaccination for COVID 1 month back. His blood pressure was on the higher side. RBS was 205. NIHS at admission was 4. So MRI brain, which was done at admission, showed him to have acute infarct in right frontal and occipital region with chronic small vessel ischemic changes. So this was the MRI, which we can see only a small infarct, which we can see in the right frontal region. So we did thrombolized him with the injection tenectase, 13 milligrams, antihypertensives like metoprolol, telmisartan, anti-diabetics, and supportive care. But however, when we repeated the imaging after 24 hours, we saw progression, as we have seen in numerous patients of stroke. You can see multiple infarcts in right frontal, some frontoparietal front, and the multiple areas, occipital also. And this patient, but however, clinically patient improved from NIHS 6 to NIHS 4, and we were able to discharge the patient on day 6. Fourth case is a bit interesting case, which I would like to discuss and get opinion from our esteemed speakers. She is a 51-year-old female. She presented with right hemiparesis 1 day back, recovered over the next 30 minutes, had at admission had no neurological deficits. She is a known case of diabetes and hypertension. Pulse was 106, BP was 167/78 at admission. MRI brain at admission was normal. So these were the two cuts which I had selected, which where MRI brain was normal. Accordingly, she was started on antihypertensive, insulin, since HbA1c was 11.6, 2D echo was normal. Neck Doppler showed complete thrombosis of left internal carotid artery. So we started her on dabigatran along with low molecular weight heparin, as we saw that. 4-vessel DSA was done, which we saw acute thrombus in left internal carotid artery. Thrombus in left internal carotid artery. And but however, 12 hours later, a patient developed right hemiparesis lasting for 1 hour, and her NIHS is 6 and NIHS was 5. So we thrombolized her with a tenectase of 12 milligrams. And after 24 hours, we started her on nimacomalone with a targeted INR of 2 to 3. Her hospital stay was uneventful, but she developed these infarcts on 24 hours after the first MRI. So our question in mind was, when we got an acute thrombus, should we have done anything different or not? And with this, I would like to discuss this patient whether we did anything wrong by starting an antiplatelet this neuro-oral anticoagulants with heparin, or we should have done something different. So I would like to discuss this case with the.
Meenakshi, you want to take it up?
Yes, sir. Thank you, sir. So the proof of the pudding is how you get the result. And when you're discussing about the fourth case, I really am very happy you got a great result actually. But
Yes,
I would
sir.
have viewed it differently, and I have a different viewpoint there.
Yes, sir.
Whenever we have an acute thrombus, yes, in a patient who has got an acute thrombus, especially a red thrombus, as you saw, we would also be tempted to use anticoagulation. Although in the routine management of TAA, anticoagulation is not, so-called within quotes an approved therapy. You need to give antiplatelet. There are two reasons. Number one, trials did not show consistent benefit with TAAs when they are treated with anticoagulation. Previously, if we remember, all TAAs would be treated with anticoagulation. But then when we saw the results of various trials, for instance, even an IV continuous heparin did not prove any benefit in TAAs, and even in recurrent TAAs, what it did was it hindered our need to thrombolize these people when they developed in-hospital stroke. Because once heparin is on board, unless the APTT is permissive, we will not be thrombolizing. So the idea of using heparin in TAAs, we were not very comfortable because of this single reason. However, when we see a red thrombus, as you saw, an acute thrombus sitting there, maybe we will be really tempted to use heparin. However, using heparin as well as dabigatran together, that would be really difficult because both are very powerful agents. Fortunately, even when you use dabigatran and heparin, both out of the box, I must say, especially because there is no data which has shown that in fact they can be given together. In fact, if you have to switch over from one agent to another agent, you should give sufficient time and then switch over. That is how the rule goes. So despite that, you got away because there was no hemorrhage. And surprising in this patient is that even when the patient was on 2 anticoagulants, the patient had a stroke, ischemic stroke. Again, there was a surprise for him because when the patient is on dabigatran, one of the criteria we use is when the patient is on dabigatran, either we don't thrombolize because it is still not within the books, or you use idarucizumab, you try to reverse that and then you give this one. There are 51 patients which were studied in this manner, which did show benefit, but we are not sure whether we can extrapolate to all our practice straight away. So lucky for you that nothing happened, and the proof of pudding, as I mentioned, is that you got away with this because there was no hemorrhage and the patient also became better. And now the patient, if there is a thrombus, we would give for 2 weeks at least, we would give anticoagulation and then we would stay with the antiplatelet. That would be my strategy in the case which you presented. We will take opinion from Saroja madam and sir. Thank you very much.
Yeah, I think I would very much agree with Dr. Meenakshi, because I would have been very skeptical to start newer oral anticoagulation along with low molecular heparin. I think I am not sure what made you choose both the drugs at the same time. And fortunately, as Dr. Meenakshi was saying, still thrombolize. This would be one of the contraindications, that within 24 hours you started both the drugs and then you would like to give thrombolysis. I would be very, very skeptical about that. And then I'm sure you would have also had that dilemma when you started in the beginning, when you saw the ICA occlusion. But the thing is that, see, 24 hours was there between the onset presentation to the hospital, the patient already had left hemiparesis. So why did you not thrombolyze in the beginning within 24 hours? Was there any contraindication for thrombolysis?
Madam, at presentation, patient had a transient ischemic attack, which had improved over the next 30 minutes. And her imaging was done at admission, which was unremarkable.
Okay.
So-
But
so
then
maybe-
you do not know when she developed. Are you very
In the
sure
hospital.
that you could document when she developed the stroke next day? Like, in between she was okay and then she has developed, or it was like, because
No,
she
she
was,
developed the stroke in the hospital itself, while she
Yeah.
was being worked up for a TIA.
Yeah, okay. So this is little controversial, using oral anticoagulation as well as concurrently you're using low molecular weight heparin. Means I would be skeptical doing that.
Yes, ma'am.
I would say
Ma'am, it
that.
was a very difficult thing for me to start, but still, whether to thrombolyze this patient or not.
One anticoagulant, one mode of anticoagulation, either the low molecular weight heparin or the newer oral anticoagulants. But start together, I am not sure. Sir, there are no guidelines to say that you use both.
And it be very powerful agents to use together, because the incidence of hemorrhage would be very high in such patients. Is that fortunately you got away with this? We wouldn't be testing it again. I think there wouldn't be any guidelines as well. One of them could be used. And even when once you have used anticoagulation, then the dilemma would come when a patient develops an in-hospital stroke. How are we going to thrombolyze them? That would be a difficult thing, especially we have patients who come with low molecular weight heparin. At least when you use regular heparin, you will use the APTT as a guide. But when a patient is on LMW heparin, you will have no guide, because factor 10A activity is not what is done routinely in any hospital. So we will not be knowing whether to thrombolyze, and better not to thrombolyze in those people. This is what guidelines we would go. Unless the patient signs a consent, we tell them, look, he may bleed, you want to take a chance, we'll do it. And nobody would actually be willing. But when he's on dabigatran, then studies have shown that you could reverse it quickly with idarucizumab, and then you could thrombolyze them with good results. Actually, patients have shown good results.
Yeah. And to Dr. Abhishek, I had one more question regarding the first case. No, it's very nice that this lady did well despite having comorbidities like and all those things. And she had a asymptomatic intracranial hemorrhage, isn't it? After thrombolysis.
Hemorrhagic transformation, ma'am, but no hemorrhage as such.
Hemorrhagic transformation only. Yeah, we would be little worried to start the oral anticoagulation so soon. She had non-valvular atrial fibrillation, or what was it?
Non-valvular atrial fibrillation.
Okay. Yeah, and then patients with uremia probably have more propensity to bleed compared to the other people.
Yes, ma'am.
But then it was nice that she could improve from,
Yes,
did not deteriorate. And it was nice. That first case was little challenging. The second case, I would still, the fourth case, I would still be, I wouldn't agree with whatever you did.
Actually, it was desperate times, desperate measures.
You must have been in a dilemma, I understand.
Yes, ma'am.
Like you said, we should be able to, stick to guidelines when it comes to a situation where you can take help from the guidelines rather than take a step giving these two together. I would reserve that.
Yes, ma'am. Sure.
Sir, can we listen to our boss, sir?
I completely agree with you. I think in the first case, I agree with Saroja that when there's a hemorrhagic transformation, I would not immediately put these patients on oral anticoagulants. See, aspirin is something else. Aspirin you can do, even if there is mild petechial hemorrhage. But oral anticoagulants, otherwise also, even if there is no hemorrhage, you don't start them right away. Even for Diner's law and all also says that you have to wait for at least 1 week. Unless the infarct is very small, it's a TIA stage. Otherwise, you have to do it because you can get hemorrhagic transformation. But your fourth case is definitely, this is for all of us to learn what we should not do. Even though the outcome is good, the outcome will be good in some patients, but in most of the patients, it's very risky. So, I just echo what our other panelists and moderators have said. The universal recommendation for all ischemic strokes, irrespective of whether there is a thrombus or what is in the heart or what it is, to give ecosprin 325 milligram on day 1. This is class 1A recommendation. Nobody can question whether you have got a atrial fibrillation, whether you have got a thrombus in the carotid or whatever you have. This is class 1A recommendation. Aspirin. So if you would have done that, that would have been the correct thing. I'm talking of day 1. Now, little departure from that can be that you may give them low molecular weight heparin. That is because, now this is not a class 1 recommendation. This is a class 2 recommendation. Where some people feel that if you actually visualize a thrombus in the culprit artery, particularly if it is mobile, then you may give them heparin. And in that case, they say that you should not give them aspirin. Then you have to give them only heparin, low molecular weight heparin, in therapeutic doses. Means 1 morning, 1 evening. This is in guideline. But then it's only heparin, not aspirin. So that could have been a correct decision. But combining dabigatran plus heparin is a risky thing. We are lucky that this patient didn't bleed, but it is an absolute no-no. And on top of it, then thrombolysis also. I mean, I'm not sure whether this patient's hematology, this is a different hematology from others. Normally, she should have bled. So this was actually contraindicated. Now, one thing is there that if the patient, dabigatran is a real contraindication because she received the dose on the same day also or yesterday also. One way to do that was to give edrasuzumab, but then she was also receiving heparin, no?
Yes, sir.
And there is no data that we can give protamine to reverse it and then thrombolyze it. So it was a overall risky procedure. But one thing is there that if you have given it, that Meenakshi also knows that if we have given a 1 dose of LMWH, then that is not a contraindication or what is called prophylactic dose. But having received regular heparin twice a day, dabigatran, giving some
only once a day, dabigatran also 1 dose, and this also heparin also 1 dose, because we did her angio in the evening. We gave her a dose, and next day morning she had this stroke.
Yeah. Now dabigatran was a contraindication.
Yes.
1 dose of heparin is not a con, but dabigatran was a contraindication. Solid contraindication.
Okay, sir.
That is what we have to learn from this case.
Yeah. She is a high risk TIA. I agree with that. You know that her chances of developing a stroke was very much there when you saw the ICA occlusion. But as Dr. Subhash Kaul sir is saying, I think we cannot be so Herculean in the beginning and taking a risk like that. We can watch for the thing, for the risk of infarction within the next 24 hours. But I guess we can learn from this patient what not to do.
Yes, sir.
What some people would have done in some case, some centers, not everywhere, in some centers when a patient is on dabigatran and there is a complete occlusion, some people would try and attempt a mechanical thrombectomy. Yes. Although mechanical thrombectomy is best done in intracranial occlusions, but now it can be attempted even in extracranial occlusions also, and to pull the clot out, suck the clot out. That is not a contraindication, even if a patient is on dabigatran or heparin. All that could have been tested, but then that depends upon the availability of the intervention.
Yes.
Yeah.
There are 2 questions in the chat box, sir.
Yeah.
I'll read out. First question is about the antiplatelets. And sir, what is the dose of antiplatelets in case we use dual antiplatelet therapy? Dr. Ritesh has asked this question. And then there is another one. First, we'll take this question, and then we'll go to 2 other questions, sir. What is the dose of antiplatelets in case we choose dual antiplatelet therapy?
Yeah. Now, one point I would like to make, one disclaimer, that when we give, it depends on, the question is about double antiplatelets, right?
Yes.
The question is about double antiplatelets, right? Now, double antiplatelets should not be given no, this I'm just telling as a general rule, should not be given immediately after thrombolysis. These double antiplatelets, we must remember, they are for minor strokes. They are for TIAs. Minor stroke means less than 5 or less than 3 even. The latest one is less than 5, this ticagrelor. And if you see the guidelines, the clopidogrel and aspirin are for those who are having less than 3. So they are not for all strokes. They are for patients who have not been thrombolized, and they are for minor strokes, and they are for TIAs, and TIAs who have got a high risk of recurrence, where the ABCD2 score is more than 5. Now the dose, it is recommended there should be, on the first day you have to give loading dose. So if you are giving clopidogrel, then you will give 300 mg of that on first day, and aspirin also you will give 325 on the first day. After the second day, you should give 75. But first day you should give loading dose because it takes time for the. So give 300 mg, 4 tablets of clopidogrel, and give 325 aspirin, and next day 75. That is the consensus about double antiplatelets. And there is another double antiplatelets which has been recently come because of TALIS trial, in that you can give even ticagrelor. That has to be given a loading dose of 180 milligrams. But the aspirin in combination with ticagrelor should never exceed 100 mg, which means 75 mg in our center. So you have to be cautious about the dose. That's a good question.
Following the earlier data on ECAS, there was also use of dual antiplatelet therapy in the form of aspirin dipyridamole combination. However, not tested specifically in the setting of thrombolysis. But beyond that, if you look at that, I think that can also be given, but not specifically tested here. So there are no choices of dual antiplatelet.
Yes.
So regarding the anticoagulation, there was one caution also. The use of anticoagulation immediately after thrombolysis again would be very difficult to justify. And there is one Diner's law which sir just mentioned. If it is a TAA, we are justified in using anticoagulation on day 1. You can just remember the rule 13612 or 13714. If it is TAA day 1, minor stroke day 3, moderate stroke day 6 or day 7, and a severe stroke, better to wait for at least 12 to 14 days, because the risk of hemorrhagic transfusion will be very huge, and we will actually cut a sorry figure. We'll be waiting for more time than I would have otherwise waited. This has been the rule which we follow. And when we have a hemorrhagic infarction, what is shown, when we have a PH1 or PH2, then we'll be more hesitant. But if it is HA1 or HA2, in fact, we are very happy, because we'll be happy that some perfusion has actually happened into the region. We are all of us are happy to see HA1, HA2. HA1 we are very happy. HA2 is still fine, but PH1, PH2 will be really disastrous for us. Though people say PH1 is also okay, so PH2 is disaster. So there is another question there, sir. I'll read out this one. The question is, if a patient has got recurrent TAA despite giving loading dose of antiplatelet within 1 day and has no neurodeficit at presentation, should we wait for another event, or we should be thrombolized? This is again from Dr. Ritesh.
No, you see question is that the patient has received antiplatelet agents and
then despite, he developed again a TAA.
Despite that,
thrombolysis.
Despite that, he is getting thrombolysis. This is a tricky situation. All of us face it from time to time. And many times these TIAs are called crescendo TIAs. That means they keep on coming. And sometimes they come 20 TIAs in a day, 30 TIAs in a day. And one of these syndromes is called capsular warning syndrome. So now the question is that, should you thrombolyze them? Well, the studies have shown that you should thrombolyze them. They invariably land with the final hemiplegia. They will get TIA, and then there will be one TIA which will not be TIA. It will be a stroke. That is their natural history. And that natural history was studied before thrombolysis. Here, there's only one tricky thing, that at what point you have to thrombolyze. ideally speaking, you should thrombolize them at a stage when he has deficit. Although some people have thrombolized even when he has no deficit, but then you will be going against guidelines. That's why. So better is to thrombolize. That's why when I have faced this situation, I tell the resident, you just be ready with the vial, and the moment he has a block, immediately break it and give it. Don't wait, because he may recover before that. Yeah, but it does help. Now, there are no studies on that, but in my experience, thrombolysis has helped in these patients, because after all, the mechanism is that there is some clot is forming again and again at the mouth of that artery. That clot is dissolving, then it's again forming. Then the clot is dissolving, then it's again forming. So once you are giving a thrombolytic agent, it dissolves it. It will not assure you, it will not guarantee you, but you have to consider thrombolytic agent in this situation, but preferably give it at a stage when he is having the deficit. Yeah, Akshay, what have you faced these situations? What do you do?
We have made our own thoughts, not guidelines, thoughts. What we do in our hospital is that I keep a guideline of about 20 minutes. Based on studies that when TIAs have lasted at least 20 minutes, they are likely to be more often associated with diffusion-weighted abnormalities and likely to be infarcts. So in our hospital, when they have recurrent TIAs, I tell them, wait for at least 15 minutes. But at 15 minutes and beyond, if a person has got, our MRI is just one floor down, you can easily take them. And we have always a green channel, good friendship with radiologists. So 15 minutes beyond, if a deficit lasts, then immediately we take them for MRI, look for deficits. With that case, if there is an infarct, then we'll be more tempted to thrombolize. 20 minutes is a guideline which we keep, not guideline, an arbitrary cutoff, sir. But when they recover within 20 minutes, then we remain happy and we do not thrombolize them. But again, every time explaining to the family is a very, very, very difficult situation, sir. And I've seen this with my own eyes, that patients who come from outside are at actually their favorites, because when they enter the emergency, they receive all the attention and they get thrombolized. We miss out on patients who develop stroke inside the hospital because our recognition is lesser than the patient's recognition per se. So majority of the times, we have found it useful to keep them in the eyes of the patient in a ward where they stay with the relatives than putting them into the ICU. Keeping them at TIAs into the ICU is disastrous because we don't really pick them up, sir. In the night, we do not know, or every time the patient be woken up 24 hours, they will not sleep. If you put them every half an hour, you do a NIHSS or D for weakness, they can never sleep for 24 hours. More disastrous, sir. This is what we have seen with the. What does Madam say?
What I would say is that, okay, from where is this TIA coming? That's what you have to see. Probably look at angiogram, CT angiogram, and demonstrate. Supposing there's a definite occlusion is there, I think still you should ask your interventional people to look at that, whether you can take it out, because it's just TIA and you already have a source. Supposing you're not able to find a source, yes. And we know that dual antiplatelets or single antiplatelet, it's not that 100% of the time they're effective in preventing another stroke. It's not just because we put dual antiplatelet, that patient is not going to have TIA at all. We know that it's about 25 to 30% that the chance reduces, but it's not that 100%. Most of the time we are happy doing it because some people may, develop a stroke later. So here I would be looking at the source of embolism and then taking a call on that rather than just deciding whether you should thrombolize them or you should go for mechanical thrombectomy. I think we should look at that part and then decide the further management. And we should know that just this dual antiplatelets are secondary prevention and not 100%. They are going to reduce the risk of an infarction. This is what I would say.
Thank you, ma'am. There is another question, sir. Can I read out, sir?
Yeah, please.
Low NIHSS in cases 2 and 3. What is a panelist's view on advancing with thrombolysis with mild stroke?
So you can answer that. You can answer that, Meenakshi.
Sir, thank you for the opportunity, sir. So my basic rule is that whatever is that, if there is a stroke, if there are deficits, I would thrombolize. That is my personalized view. But then when you look at the literature, whether low NIHSS should be thrombolized, the answer is that if the person, there are criteria to say what is a milder stroke. When the NIHSS is too low, then we call it a minor stroke. But again, there are a lot of exclusions. For example, if a person has got a hemianopia, the NHS will only 2. But if you leave them without thrombolysis, they are going to have a disaster.
Yes.
So any patients who have got a low NHSS, excluding a hemianopia or an aphasia, they should be thrombolized. But however, even there they say that you can exclude them, but if the patient says that whatever deficit, for instance, even if there is a minor sensory symptom, and for you and me, a sensory symptom may qualify for NHSS 1. But if a sensory symptom is there, it can be so annoying. In fact, Professor Dr. Kaul sir mentioned in one of the previous meetings about this. Why should you leave them and have them in the window? There is no need to actually leave them. And sir also shared his experience about thrombolizing them. What is wrong? If a person has got an infarct and the pressure deficit, it may qualify for NHS 1, but the patient is right there with the what guarantee will not further test. Previous data on risk patients, the so-called rapidly improving stroke symptoms. What do we do with them? Do we thrombolize them just because they are improving? The fact is that even when they are not thrombolized and they were observed, it was seen that many of them, a big chunk of them actually could not even be discharged home. They actually went to a hospice. So my take on that will be is that by definition, low NHSS less than 3, which are non-disabling in nature, they may be left back, but there is no reason for us to leave them because low NHSS means the chance of bleeding is also very low. What may appear disabling for us is not what will be perceived by the patient, and I will be tempted to thrombose. Sir also mentioned this in the previous one. Am I correct, sir?
Yeah, absolutely. Yeah.
So regarding the first speaker, I had one thing to ask you, sir. That person was a very young man, and whatever was presented, the first speaker when he presented, she was when he presented that. The point was, he had an intracranial disease. He showed ICAT. He showed, so he could just highlight to us what was his thoughts on intracranial artery disease in a young man like that.
Is it there?
Shastara.
Dr. Shastra.
Dr. Shastara, I think, he is disconnected, sir.
Okay, because he mentioned about an intracranial arterial fluid. I mean, there was an ICAT. So, but he mentioned that there was only one side that was affected. It was a young man. So I was just wondering whether it was actually a migrainous infarction or something, sir. Any thoughts on that, sir? It would have been that or anything else, sir? Because no, why should a man have a single large occlusion on one side, being so young, presenting with stroke, with other vessels being normal?
Dyslipidemia was there for him. This man had dyslipidemia. Already some risk factor was there for him.
No, I think the first case is probably hypertension, diabetes also. That's what I noted down.
He mentioned only about the dyslipidemia. Madam, when we look at the data on dyslipidemia and stroke, the association with dyslipidemia with atherosclerosis is very strong.
Yes.
But the association of dyslipidemia with stroke is not very strong. Only when there is an extreme dyslipidemia, cholesterol more than 340, 350, LDL more than 200. If that extreme forms of dyslipidemia, as it is fine. But when you look at the majority, they have a total cholesterol of 220 and LDL of about 120, 130. So he did not qualify what was the degree of dyslipidemia in that case. And again, the thing was that only one vessel was affected. If dyslipidemia, I would have expected that the other vessels also showed some abnormality here and there. Say 30% on the left side, 40% on the right side, then it is okay for me. One vessel having almost complete occlusion, near occlusion, another vessel was normal. So I was wondering whether it was migraine, dissection, conditions like that, rather than dyslipidemia related stroke.
Correct. I agree with you. Meenakshi, you're right.
Yes, we see these young patients coming with this ICAD, and then we see here at least we are looking at that. We see them to have this tobacco consumption, homocystinemia. We see very young patients, 18, 20 and all coming with this ICAD. Probably he told all the risk factors were looked for, and then they did not find. So I wonder whether there was any prothrombotic state. We are not sure about that part.
Anyway, I think he has left, and but for those who are attending, it's important to do complete investigation. A lot of times it turns out to be dissection.
The common risk factors for ICAD includes dissection. Then we have to consider cerebral vasoconstriction syndrome, fibromuscular dysplasia, vasculitis. That would be the list which we'll go through. But this patient probably, I think that young man probably would have a migraine and would have got a dissection. That is my guess in that case.
Yeah.
I think yes.
So I think it is 9:16 already. We have
Yeah.
The time.
So, sir, with your permission, can I close the session, sir?
Yes,
Yeah.
of course.
Yeah.
If you
Thanks
have
a
any
lot, sir.
question, tell us in person.
With Saroja's and Meenakshi's permission.
Sir,
Thank you, sir. When you are there,
We
your
follow-
permission is most important. Thank you very much, sir.
Thank you.
So,
Yes, sir.
thank you very much, doctors. Today we had 159 doctors, those who have listened to this wonderful session in last 1 hour, 20 minutes. We had interesting presentation by Dr. Abhishek as well as by Dr. Shastara. I take this opportunity to thank you both of them for showing their clinical cases and making all doctors more knowledgeable. Special thanks to Dr. Saroja ma'am for being our guest moderator for the day, and Dr. S. Meenakshi Sundaram sir for continuously moderating the session. Thank you very much, sir. Dr. Subhash Paul, thank you very much for your continuous guidance, mentoring, and today's session course coordination. Thank you very much, sir. Thanks a lot once again to all of you, and we will look forward and once again meet next month. We'll communicate the dates and agenda
Namaste.
in advance. Thanks a lot, sir.
Thank you very much.
Sir.
Thank you, sir. Thank you.
Madam, thank you, madam. Sir, enjoy Goa, sir. Thank you.
Thank you.
Yeah.
Thank you. Have a
Thanks a lot.
wonderful day. Thank you all. Thank
Saroja
you.
madam, thank you.
Thank you.
Bye.
Happy see you. See you. Okay. Bye. Bye. Have a good day.
Madam, respect to sir also. Please convey your regards to sir also, madam.
Oh, sure, sure. Thank you so much. I will. Okay. He's writing a chapter, so he's busy. Yeah.
Bye, madam. Bye.
Take care.
Bye, ma'am. Bye, sir.
Bye.
Sir, I'm ending the meeting, right?
Yeah.
Yeah.